Alterations of digestive function in children. Cleft lip and cleft palate are common congenital malformations that may occur alone or as part of a syndrome. Syndromic cases are associated with chromosomal, Mendelian, or teratogenic syndromes, while non-syndromic cleft palate occurs in isolation. These defects originate from disruptions in embryonic development. Both genetic and environmental factors may contribute. Cleft lip results from incomplete fusion of the nasomedial or intermaxillary processes during the fourth week of development. The defect typically appears beneath one nostril, but it can be bilateral and either symmetrical or asymmetrical. This abnormality disrupts the normal continuity of the upper lip. Early diagnosis is usually made during prenatal screening or at birth. Cleft palate often accompanies cleft lip, but it can also occur independently. The defect may affect only the soft palate and uvula or extend forward to involve the hard palate and alveolar ridge. This condition can significantly impact feeding, speech development, and facial structure. Surgical correction is usually necessary within the first year of life. These facial malformations are usually recognized immediately at birth due to their visible presentation. Feeding difficulties are a primary concern, especially in infants with cleft palate. Evaluation includes prenatal imaging and thorough postnatal assessment. Treatment typically involves surgery, speech therapy, and long-term follow-up with dental and orthodontic specialists. Cleft conditions are best managed by a multidisciplinary team. These may include surgeons, speech-language pathologists, prosthodontists, and pediatricians. Surgical repair is often done in stages to accommodate growth. Early intervention helps reduce long-term complications and improves quality of life. Esophageal atresia is a congenital defect in which the esophagus ends in a blind pouch rather than connecting to the stomach. It is frequently accompanied by a tracheoesophageal fistula, or TEF, which creates an abnormal connection between the trachea and esophagus. This condition often coexists with other anomalies. Prenatal diagnosis may be suspected with polyhydramnios and confirmed if a nasogastric tube cannot be passed after birth. Infants with esophageal atresia cannot swallow properly and often drool or choke during feeding. Immediate recognition and surgical correction are essential. Without prompt intervention, the condition can lead to aspiration, pneumonia, and severe respiratory distress. Postoperative care focuses on preventing complications and ensuring adequate nutrition. Pyloric stenosis is a narrowing of the pylorus, the passage from the stomach to the small intestine. Though the exact cause is unknown, it typically presents between 2 and 3 weeks after birth. Affected infants experience forceful, non-bilious vomiting shortly after feeding. This condition can lead to dehydration, weight loss, and metabolic imbalances if not treated. Infants with this condition are often irritable and hungry due to feeding difficulties. On physical exam, a small, firm, mobile mass, often described as an olive, can be felt in the right upper quadrant. Diagnosis is confirmed via ultrasound. The definitive treatment is pyloromyotomy, a surgical procedure that relieves the obstruction. Duodenal obstruction is a congenital or acquired blockage of the first part of the small intestine. Clinical signs include upper abdominal distension, visible peristaltic waves, decreased passage of meconium, weight loss, and persistent vomiting. These infants are at risk for dehydration and malnutrition. Imaging often reveals the classic double bubble sign, which indicates gas trapped in the stomach and duodenum. Obstructions in the jejunum or ileum may result from atresia, stenosis, intussusception, meconium, or volvulus. These blockages can be either partial or complete and often require urgent intervention. Clinical signs may include abdominal distension, failure to pass stool, and bilious vomiting. Prompt diagnosis and surgical correction are essential to prevent bowel necrosis and long-term complications. Malrotation occurs when the small intestine does not rotate properly during fetal development. This leaves it loosely attached and prone to twisting upon itself, a condition known as volvulus. Most cases present in the neonatal period. Malrotation is a surgical emergency due to the risk of bowel ischemia. Infants with malrotation may experience bile-stained vomiting, abdominal pain, dehydration, and signs of bowel obstruction. Bloody stools and fever can occur if the condition progresses. Diagnosis is confirmed by imaging, usually with an upper G series. Surgery is required to untwist the intestine and prevent recurrence. Meconium is a congenital outpouching of the small intestine, often found in the ileum. It follows the rule of twos. Occurs in 2% of the population, located about 2 feet from the ileocecal valve, and is about 2 inches long. Most cases are asymptomatic, but some children may present with painless rectal bleeding. Complications include intestinal obstruction, volvulus, and intussusception. Meconium syndromes refer to conditions in which thick, sticky meconium causes intestinal blockage in newborns. Meconium ileus is the most serious type and can be simple or complex. It often occurs in infants with cystic fibrosis. Complex cases are a medical emergency due to the risk of bowel perforation and sepsis. Meconium plug syndrome is a transient form of obstruction. It is marked by delayed passage of meconium and dilation of the colon. In contrast, distal intestinal obstruction syndrome occurs in older children with cystic fibrosis, where sticky fecal matter blocks the terminal ileum and proximal colon. Both conditions require prompt evaluation and management to avoid complications. In meconium syndromes, the terminal ileum is often impacted with thick meconium due to abnormal mucus production. Peristalsis fails to move the material, resulting in obstruction. Symptoms include abdominal distension and vomiting soon after birth. Diagnosis is made with abdominal X-rays, and treatment involves intestinal lavage or the use of laxatives to clear the obstruction. Hirschsprung disease, or congenital aganglionic megacolon, is caused by the absence of parasympathetic ganglion cells in the colon. This leads to a functional obstruction because the bowel cannot relax and move stool forward. The affected segment becomes distended, often resulting in chronic constipation and abdominal bloating. Surgery is required to remove the non-functioning segment. The severity of Hirschsprung disease varies. Some children may have mild constipation, while others may develop severe obstruction, diarrhea, or even life-threatening enterocolitis. Sepsis is a major risk if the condition is not treated early. Surgical resection of the aganglionic segment remains the definitive treatment. Management of Hirschsprung disease doesn't end with surgery. Postoperative care is essential to monitor for complications such as strictures, leakage, or continued motility problems. Some children may experience constipation even after resection and require long-term dietary management or medications. Early diagnosis and ongoing support can significantly improve outcomes and quality of life. Anorectal malformations include a spectrum of congenital defects such as anorectal stenosis, imperforate anus, and rectal atresia. These abnormalities often occur alongside other birth defects involving the spine, kidneys, or heart. Diagnosis is typically made during the newborn exam, and symptoms include failure to pass stool or abnormal anal positioning. Management depends on the severity, but usually involves surgical correction. Treatment of anorectal malformations varies from simple dilations for mild cases to staged surgical repairs for complex defects. Long-term follow-up is important as some children may experience issues with continence, constipation, or urinary tract problems. A multidisciplinary team approach ensures the best outcomes, with pediatric surgeons, gastroenterologists, and urologists all playing key roles. Gastroesophageal reflux is common in healthy infants and usually resolves without treatment. GERD, however, occurs when reflux causes significant symptoms or complications, such as poor weight gain or respiratory problems. The underlying cause is often a relaxed or underdeveloped lower esophageal sphincter. In infants, regurgitation is frequent, but not all cases require intervention. Symptoms of GERD in infants include excessive vomiting, food refusal, crying, gagging, and even choking. Severe cases may lead to esophagitis, bleeding, or strictures. Diagnosis is often clinical, but more persistent cases may need pH monitoring or endoscopy. Treatment includes feeding changes, medications, and in some cases, surgical intervention such as a Nissen fundoplication. Intussusception is a serious condition where one part of the intestine telescopes into another, causing a bowel obstruction. The most common site is the ileum slipping into the cecum through the ileocecal valve. This leads to compromised blood flow, swelling, and eventual tissue death if untreated. Prompt intervention is critical to avoid perforation or sepsis. Children with intussusception often present with sudden abdominal pain, irritability, and vomiting. A classic symptom is the passage of currant jelly stools, which are stools mixed with blood and mucus. Diagnosis is usually confirmed with ultrasound. Treatment typically involves reduction with a contrast or air enema. If unsuccessful, surgery is required. When non-surgical reduction fails or complications like perforation arise, emergency surgery is performed to correct the intussusception and remove necrotic tissue. After reduction, children are monitored closely for recurrence, which can happen in some cases. Early detection and treatment are crucial for a full recovery and avoiding long-term intestinal damage. Cystic fibrosis is an inherited disorder that affects the exocrine glands, leading to thick secretions in the lungs and gastrointestinal tract. In the digestive system, it causes obstruction, infection, and chronic inflammation. Pancreatic enzyme deficiency results in poor digestion of proteins, fats, and fat-soluble vitamins. Clinical signs include steatorrhea, abdominal distension, and poor growth despite a good appetite. Celiac disease is an autoimmune disorder triggered by ingestion of gluten, a protein found in wheat, rye, barley, and malt. In affected children, gluten exposure leads to immune-mediated damage of the small intestinal villi. This disrupts nutrient absorption and can lead to a wide range of symptoms. Genetics, diet, and immune factors all contribute to disease onset. The onset of celiac disease varies depending on when gluten is introduced into the child's diet. Some children show symptoms shortly after exposure, while others may remain asymptomatic for months. Severity also ranges widely, from mild bloating to severe malabsorption. A potentially life-threatening complication, known as celiac crisis, involves profuse diarrhea, dehydration, and electrolyte disturbances. Diagnosis is confirmed through serologic tests for autoantibodies and sometimes intestinal biopsy. The only effective treatment is strict lifelong adherence to a gluten-free diet. Eliminating gluten allows the intestinal mucosa to heal and prevents long-term complications like growth failure or nutritional deficiencies. Ongoing education and support are essential for patient and family compliance. Malnutrition results from an imbalance between nutrient requirements and intake. It can also occur due to poor absorption, increased nutrient loss, or higher metabolic demands. Children with chronic illnesses, poor access to food, or behavioral feeding issues are especially at risk. Malnutrition can affect every system in the body and impair both physical and cognitive development. Protein energy malnutrition includes conditions like kwashiorkor, which is due to protein deficiency, and marasmus, which results from overall caloric deprivation. Signs include muscle wasting, diarrhea, anemia, and infections. Children may appear thin with little subcutaneous fat, and in severe cases, may show signs of edema. Malnutrition can cause long-lasting delays in physical, behavioral, and cognitive milestones. Previously called failure to thrive, faltering growth is characterized by slower than expected weight gain in infants and young children. Clinical signs include a low weight for height ratio or poor weight relative to height and head circumference. This condition is often multifactorial, involving biological, psychosocial, or environmental components. Early identification allows for timely nutritional and developmental intervention. Necrotizing enterocolitis, or NEC, is a life-threatening gastrointestinal emergency in neonates, especially those born prematurely. It involves ischemia and inflammation that lead to intestinal necrosis and sometimes perforation. The exact cause is unclear, but prematurity and immature gut defenses are major risk factors. NEC is the most common serious GI disorder in newborns. Many factors contribute to NEC, including infection, abnormal bacterial colonization, and immature intestinal motility. Altered blood flow and exaggerated inflammatory responses also play a role. Stress around birth, feeding practices, and genetic predisposition are additional risk factors. Together, these elements compromise the integrity of the intestinal barrier and increase vulnerability to injury. Clinical symptoms range from mild abdominal distension to signs of bowel perforation like bloody stools and septicemia. Diagnosis is based on clinical findings, labs, and abdominal imaging. Treatment involves stopping feedings, decompressing the stomach, administering antibiotics, and sometimes surgery to remove necrotic bowel. Early intervention significantly improves survival and reduces long-term complications. Diarrhea in children involves an increase in the water content, volume, or frequency of stools. It can be either acute or chronic, but in children, even short episodes can lead to serious dehydration due to their smaller fluid reserves. Acute infectious diarrhea, especially from rotavirus, is a leading cause of death in young children worldwide. Prompt fluid and electrolyte replacement are critical in managing these cases. Primary lactose intolerance results from a deficiency in lactase, the enzyme responsible for breaking down lactose in the small intestine. Undigested lactose leads to osmotic diarrhea, as well as abdominal pain, bloating, and gas. It typically appears later in childhood or adolescence and varies in severity by genetic background. Management includes reducing or eliminating lactose-containing foods and using enzyme supplements when necessary. Neonatal jaundice presents as a yellowing of the skin and sclera due to elevated bilirubin levels. It becomes clinically apparent when bilirubin exceeds 2 mg/dl. Jaundice is extremely common in newborns and can be physiologic or pathologic. Understanding the type and timing is important in distinguishing normal patterns from serious conditions. Physiologic jaundice is most common in healthy newborns and results from immature liver function and increased red blood cell breakdown. It typically appears around day 2 to 3 of life and resolves without treatment. However, jaundice can also be related to hemolytic disease, infections, metabolic conditions, or liver disorders. Persistent or early onset jaundice requires further evaluation. Pathologic jaundice is more serious and may be caused by conditions like blood type incompatibility, prematurity, or enzyme deficiencies such as G6PD. Risk factors include male gender, exclusive breastfeeding, and delayed stool passage. Left untreated, high bilirubin levels can lead to kernicterus, a form of brain damage. Early detection and phototherapy can prevent complications. Biliary atresia is a rare but serious congenital disorder where the bile ducts are absent or blocked. This leads to bile accumulation, liver inflammation, and eventual cirrhosis. Jaundice is the primary early sign and typically appears within the first 2 weeks of life. Surgical intervention with the Kasai procedure may delay liver failure, but most children eventually require liver transplantation. Hepatitis in children can be caused by several viruses. Hepatitis A often spreads through contaminated food and water, with many infections occurring in children. Hepatitis B can be passed from mother to child during birth and may progress to chronic infection. Hepatitis D requires co-infection with HBV, while hepatitis C is usually transmitted through blood. Chronic hepatitis B and C are the main causes of long-term liver damage in children. Though cirrhosis is less common in children, chronic liver diseases can still lead to fibrosis and irreversible liver damage. Pediatric cirrhosis carries the same complications as in adults, including portal hypertension and liver failure. Children may also experience growth failure, nutritional deficiencies, and developmental delays. Early treatment of the underlying liver disease is essential for improving prognosis. Several inherited metabolic disorders can affect liver function. Wilson disease is an autosomal recessive condition that causes copper buildup in the liver, brain, and eyes. Galactosemia results from a deficiency in an enzyme needed to break down galactose, leading to toxic accumulation in various organs. Both disorders require lifelong dietary restrictions and careful monitoring. Fructosemia is another autosomal recessive disorder caused by a deficiency of fructose 1-phosphate aldolase. This leads to toxic buildup of fructose in the liver and other tissues after ingestion of fruit or sugar. Affected infants may present with vomiting, hypoglycemia, and failure to thrive after starting solid foods. Avoidance of dietary fructose is the cornerstone of treatment.